Okay. Um, at this point, in the lab, I would have wanted us to have looked at the first video that I recorded on postural types. And then I would have wanted either myself or Ben to have gone over the examples of good and not so good posture. And then I would like to start with this test of length. And the file number, it's a PDF file in the posture folder, and it's file 0026. So what I'm going to do here is to go through each of the tests for length. And this would be, again, a test of the flexibility of those muscles that we're talking about. And then after I go through each muscle, Ben and I will go ahead and stop the recording and then have you practice the testing the length of your lab partner, the flexibility of your lab partner for that particular test. So the first one that we're going to look at, see if I can find it here. Okay, that took me a second. I had to find how to share it. So here's the file, and the first length test that we're going to do is to test the length for the hip flexor muscles. And this is a picture of Florence Kendall, although you can't see her very well. But she indeed is one of the heroes and pioneers of our profession. And she literally wrote the book on muscles and posture. So this is also called the Thomas test, THOMAS, the Thomas test, to assess the length or the flexibility of the hip flexor muscles. Before we begin, I would like to mention that there are two hip flexors. There is the one joint hip flexor, which is the name of it is the iliopsoas, and there is a two joint hip flexor, meaning it crosses two joints, and that one is the rectus femoris of the quadriceps. It crosses both the hip and the knee. And so part of the Thomas test is we're trying to determine, is this decreased flexibility or shortness of the muscle coming from the iliopsoas, or is it coming from the rectus femoris? And so Florence goes through the test, how to perform the test. You're going to have the patient's low back and their sacrum flat on the table. If you have the patient bend this opposite knee up too much, the sacrum is gonna pop up off of the table and skew the test, or that will be an inaccurate test. So you can assist the patient to a supine position. I usually have them grab hold of my forearm, and then we lower down easily, and I can kind of help keep this leg in flexion. If they have back pain, you don't want them to go straight back with their legs out straight. That's going to create too much stress on the low back. So you can assist them down into this position. Now, in the diagram, it's the right leg that we are looking at. You do not want to, you're just going to assess where the leg naturally falls. And so with normal length, normal length of both the 1 joint and 2 joint, there should be, actually I'm going to come down here. Sorry, I'm skipping around a little bit. I think it's, yeah. For normal length, the thigh should stay on the table and the knee flex to 80 degrees. That's what you're seeing on this page number 378. So we'll just look at the normal length first. The thigh will give you information about the iliopsoas. So whatever the thigh is doing on the table, that's what the iliopsoas is doing. The knee will give you information about the rectus femoris. And then we're going to look at 4 different scenarios. There's 4 different things that can happen with the Thomas test. So before we have you guys, practice on each other how to perform the test, what you're going to do is you're going to assist your patient down into this supine position. You can help them sort of cradle that leg as you go back. And then in this case, we are looking at the right lower extremity. If there is normal length of iliopsoas and the rectus femoris, the thigh will lay on the table and the knee will flex to approximately 80 degrees. So what you're going to do for this test is you're just going to take your goni out and you're going to put your, your fulcrum, just like we've always done it, your fulcrum at the axis of the knee, the distal arm lined up with the lateral malleolus, and the proximal arm lined up with the greater trochanter. And you're going to look at that angle. So if the patient has, or you have adequate length of both of your iliopsoas and your rectus femoris, also called your 1 joint and your 2 joint hip flexor, it will look like this. Now, the 3 other alternatives could be, let's go back up here to the top. It could be that the 1 joint hip flexor has normal length, but there's shortness of the 2 joint hip flexors. So in this case, again, the thigh is going to give you information about the iliopsoas. And so as you're taking notes, I would write down 4 different scenarios. 1 is the normal length that we just talked about, thigh on table, knee flexes to 80 degrees. The second possibility is that there's normal length of the 1 joint, which is the iliopsoas. In this case, the thigh will be on the table. You go ahead through the other steps of getting the person into that test position, and then you look at the thigh. But there's shortness of the 2 joint, which is the rectus femoris. And so the knee does not flex to 80 degrees. This is, this is not 80 degrees. So you can measure that with your goni, but if it looks like the leg is kicking out like this, then that means that there's shortness of the 2 joint hip flexor, which is the rectus femoris. So that is the second possibility. The third possibility, as you're writing down and documenting your scenarios, is that there could be shortness of the 1 joint, which is the iliopsoas, but no shortness of the 2 joint, which is the rectus. So if the iliopsoas is short, the thigh is going to pop up off the table. So you're initially going to always look at the thigh position first. If it touches the table when the test is done correctly, then that is a normal length of the iliopsoas. If the thigh comes up off the table, that means that the iliopsoas is shortened or tight. Now then, you can go ahead and measure the angle of the knee. you can see here, this knee is probably at least flexed to 90 degrees. So that means that rectus femoris, or the 2 joint, is okay. It's of normal length. That is the third possibility. And the fourth possibility is that I'm going to bounce over this tensor fasciae lata and sartorius thing for a second, a little bit out of order on the pages. But the fourth possibility is that there are shortness of both 1 joint and 2 joint muscles. So shortness of both iliopsoas and rectus femoris. So again, you have the patient assume the test position. Remember, you want the low back and the sacrum flat on the table. You don't want them pulling this knee up too far and bringing the sacrum up off the table. Otherwise, it will look like iliopsoas is shortened when it might not be. But in this case, the thigh is off the table, so that means the iliopsoas is shortened, and the knee is not flexing to 80 degrees, which is indicative of the rectus femoris being shortened. So here in a moment, when you stop the video, I want you to test each other and see if you have normal length of both or the other 3 possibilities. Shortness of the 1 joint, normal of the 2 joint, shortness of both of them, or shortness of 1 joint, normal of 2. I'm not sure if I said that right, but go by these diagrams and figure out which one of those possibilities that you are. Have your lab partner test you with the GONI. Now, Florence Kendall was also so good at what she did that she actually broke out and used the Thomas test to see if there was shortness of the tensor fasciae latae or the sartorius. She even used it to test for that. Most of the time in the clinic, you're only going to see that it's used for the 1 joint or the 2 joint hip flexors. But what she said is if you looked at this bird's eye view and you looked at the hip and the knee, then on tensor fasciae lata, the hip would be abducted, it would be flexed, it would be internally rotated, and the knee would extend if the tensor fasciae latae were tight. If the sartorius was tight, the hip would abduct, it would flex. Here's the difference. It would externally rotate the hip and it would flex the knee. So that's a little bit nuts to know, but that's really how good Florence Kendall was at this. So we've looked at the four different possibilities. It's always going to be important when we look at these tests that we do the test correctly and that we identify the errors in the test. So the big one for here is that the low back is flat and the sacrum is on the table. Now you can kind of see here when you're testing this in the clinic, you really, because you're going to start from a sitting position with your patient. And so you really don't want this knee sort of butting up against the table. So you've really got to set that patient way out on the edge of the table almost to be able to get the knee position correctly. So when you're stopping to do that, you're probably going to have to come out on the table much further than what you think. But the error in the test is when the patient is pulling the knee too far toward the chest. And you can see that this was actually a normal position, but when he pulled his knee excessively toward his chest, the thigh popped up. And so that is the error of the test. So just make sure that, the patient does not do that. Okay, so now here, I want you to stop the recording and and then you go and test, each person tests their lab partner, each person be the patient and the therapist, and document your findings, okay? So then the next test is the Ober test, and it is also called the abduction test. And what we are doing here is we are testing for length of the IT band, the iliotibial band. Kendall also had a modified Ober, and so we'll look at the differences there. So you can go through the description. She listed out the procedure here. You can read through all of that if you want to. You should always assess both sides. But what you're going to do is you're going to widely abduct the thigh, and you're going to hyperextend it. Now, in this picture, we're assessing the leg that's on top. So we're assessing the right leg. The bottom leg, you want it with the hip and knee flexed. So if the test is negative, meaning they have normal length of the IT band, this thigh will drop below the horizontal plane because it's got enough length to stretch over both the hip and the knee. If there is tightness there, and some of you may have it, it will literally look like a board. It will not drop below the horizontal. It will just stay there. The muscle is tight enough that it kind of stands it up there like a board. And so with all of these things, if we have tightness, what we're going to lead up to is how do we correct it with exercise. Now, Kendall also looked at the modified Ober, which was with the knee extended. It was the same thing where you widely abduct the leg, hyperextend, and then let the leg fall. If it falls below the horizontal, that is negative, meaning that there is adequate length of the IT band. And so she shows you some pictures here, tightness. You see that she is not supporting that leg. The IT band is tight enough that it is keeping the leg in that position. The tensor fascia lata in particular, blends with the IT band. So you may hear me say, kind of using those terms interchangeably. Now, what you want to look for is you've got to look for the error in the test. So there's two things that can happen here. Either the trunk on the side that they're laying on, the trunk can pop up and let that leg come down. It'll look like the leg's coming down, but it's really the trunk on the other side that's bending. So that's one error of the test. The other is to let the knee internally rotate. You've lost the stretch if you do that. So those are the two errors of the test. That is called the Ober test. It is to test for TFL and/or I call it IT band tightness. So now I would like you to stop the tape, and I would like each person to be the patient and the therapist, and that you go through the Ober and the modified Ober with each other, and you document your findings. It's going to be important that you document your findings, because we're going to then take those back up and see if they match with the postural type that you had. So now we've done that. The next one is the hamstring length test. You will notice here, this is important, that the contralateral limb stay flat on the table. In other words, this knee is not flexed up. It's flat on the table. That's the proper way to do a hamstring stretch, because once you flex up the knee, again, this is going to look like there's more length in the hamstrings than what there really are. So this is a pretty simple one. we see here the use of the passive insufficiency of the hamstrings. Remember, the hamstrings extend the hip and flex the knee. So to create passive insufficiency, we're going to have to do the opposite of its actions. So we've got the hip flexed and the knee extended. Very common in the clinic. And I always joke around because every time I see an advertisement for physical therapy, they are always doing the hamstring stretch, always. But our patients do have tightness, a lot of tightness in hamstrings from an orthopedic standpoint and a neurological standpoint. It's just a muscle that gets very, very tight. So for the normal length, the sacrum is flat on the table. This leg should be the angle of approximately 80 degrees between the table and the raised leg is said to be normal hamstring length. So you're looking at this length, and so you can assess that, put the fulcrum where it goes on the hip and measure this angle. Now you want to stop the stretch. If the knee begins to flex, you've got to back off. The knee needs to be extended here. So if you feel knee flexion happening or see it, then you need to stop the test, and then that's where you measure the angle. So lots of people have hamstring tightness. Here is an example of excessive hamstring length. My goodness, this gal looks like she was maybe a gymnast or something of that sort. Our patients with spinal cord injuries need excessive length of their hamstrings as well, more than that 80 degrees. But you can measure this. And so since all of this is measurable, then that's where you can say that, you know, you have a measurement that says, this is how I know that this hamstring is tight or not tight. So at that point, I would like you again to stop the tape. Everybody measure each other's hamstring length, document it, and we'll, after you get that one done, then we'll go on to the next one. Now, the next length test, we're going to look at this forward bending. Actually, when we bend forward to touch our toes, the hamstrings are also involved. And for normal length of the hamstrings, the patient should be able to touch their toes. The other thing that we're going to use this long sitting test for and reaching for the toes is, this is a little bit more subjective, but is to measure, or at least to eyeball, the length of the paraspinals. So if the length of the paraspinals are accurate, are consistent, you will see just a gentle C-shaped curve. And so remember, we said with excessive lumbar extension or excessive lumbar lordosis, these paraspinals or these lumbar extensors are going to be too tight. And that's how we're going to test it. We're going to have the patient in long sitting, reaching for their toes, and we're going to be analyzing these curves. You can almost see in this curve, there's a little bit of flattening here. So that one is a little bit more subjective as far as the length of the paraspinals or the erector spinae, but there's going to be very specific strength tests. So between what we notice with the postural type, what we notice here, and what we notice with the strength test, I think you will find those to be pretty consistent. So go ahead and stop the tape and assess each other's paraspinal length. The next one is the length for the pec major, the pectoralis major. We have you learn this muscle as one large muscle, but it does have a clavicular head and a sternal head. In all the years I've tested this in the clinic and with students, I rarely find that this test shows a lack of pec mobility. I think there's an easier, or there's a better way to determine it. Now, really, if the person has forward shoulders, you can almost bet that they have tight pecs. But and I'm not going to argue with Kendall. She's one of my heroes. I'm not going to tell her how I think her book should have been written, but we'll just look at it. I'm just saying in my experience, it's been that way. But normal length of the lower fibers, the arm is abducted out to here to about 100, well, she's got 135 degrees of abduction. If that arm rests on the table, then it has normal length of pec major. If it pops up off the table, then that would be a shortening or a decreased length. Normal length of the upper fibers, we have the arm abducted to 90. The arm should rest on the table for normal length. If it pops up off of the table, that would be tightness of pec major, according to Kendall. She's got, she looks at some excessive length here. Honestly, this length for pec major is what I tend to look at, which I know pec major and pec minor are different. But I think in this picture, you can see, if you're looking at the patient from this angle, you can see that the right side, the acromion, is higher because it's drawing that shoulder, that glenohumeral joint forward. So, I think between what you see on the plumb line, what you see from the lateral view, and then maybe what you see from here, you can tell if there's pec tightness. Now, up until now, we've talked about using the corner stretch to stretch the pec major and the pec minor. But really, if you think about it, in the corner, the heads of the humerus are just going to sort of ride forward, and that's not what we want. That's what is happening when there's shortness of those muscles. So I think there's a better way to do it, and that's to do it manually here with the patient. You have them positioned here, and then you simply take your hand and you stretch, you push down against the attachment, and that will give a better stretch, in my opinion. That's how I would do it in the clinic. So you can go ahead and stop the tape and look at length of pec major, the sternal head and the clavicular head. Now, we're going to come back. We've got just a few more. We're looking at the length of the shoulder rotators. I want to highlight this. If I could be in the room jumping up and down and clapping and trying to get your attention, I need you to pay attention to this. This is the test for length of the shoulder rotators. So you see medial rotators. This is not a typo. If I'm going to assess the length of a muscle, then I have to make it go in the opposite direction of its actions. So that's why we are seeing the arm in lateral rotation. So for normal length of the medial rotators, then the normal range of motion is 90 degrees of lateral rotation. That is not a typo. That is because, again, for length of a muscle, if you're going to assess it, you have to have it go in the opposite direction of its actions. If I want to assess the length of the lateral rotators, I'm going to put the arm in medial rotation. So I have, go back to the way I measure this. I've got 90 degrees of abduction, 90 degrees of elbow bend. and then I measure. Now I would say on this one, when you're assessing the length of the lateral rotators, watch the head of the humerus. If there's tightness, that head of the humerus is just gonna roll up and you've lost the stretch. So you want to make sure that you're holding that head of the humerus down, and as soon as you feel it begin to pull anteriorly, you're going to stop and take your measurement. So normal range of motion there is 70 degrees. Now, I'm talking about 70 degrees of the motion of medial rotation, but that is assessing the length of the lateral rotators. And so I go over this, I try to highlight this year after year, and it seems like inevitably on tests or quizzes or whatever, people miss that. So when you're looking at a quiz question or a test question, make sure it's asking you, or make sure you know what it's asking you. If it's asking you for length, then that is the opposite of its actions, of its muscle action. And Kendall did a cool thing here. She looked, I think this person was supposed to be a baseball player. And here's an excellent example of a muscle imbalance. Look at all of this excessive motion on this side of the joint. And then this is all he had on, for the length of the lateral rotators, not much length at all. And so, you know, that's why some of our athletes can be set up for things like rotator cuff injuries if they have, you know, super significant change in their joint axis. And then the last length test, we're gonna, please pause the tape and measure each other's rotators. Say to yourself over and over and over again, when I'm looking at lateral range of motion, lateral rotation range of motion, I'm looking at length of medial rotators. When I'm looking at range of motion for medial rotator with the GONI, I'm looking at length of the lateral rotators. And then you could, you know, you could stretch it out and even name those muscles. And I know that you can do that if I quiz you hard enough. But say it over and over and over again until you get it. So pause the tape and measure each other's rotation. Then we're going to come back and we're going to look at tests for length. I just call it the latissimus dorsi length test. Kendall threw in the teres major and the rhomboids as well. But what you're going to do is have the patient in hook lying in supine. Oops, going the wrong direction on the scroll. So this is the hook lying position in supine. You're going to keep the low back flat on the table and then do a bilateral arm raise. For normal length, the low back should stay on the table and both arms should touch overhead. If there is shortening, there will be an increased lordosis of the lumbar spine. The lumbar spine kind of pops up, and or the arms will not touch the table. That's how that you know that there is latissimus dorsi tightness. So you can go ahead and stop the tape and look at each other's there. So as we finish here with the length tests, what we're going to do, and I'm hoping that you documented everything, then we're going to go back and we're going to say, okay, this is how we know per the 4 basic postural types that Kendall coined. This is how we know now that the hip flexors are tight. You know, if we looked at the kypholordosis and we said the hip flexors were tight, now we know how to measure for that, and we can definitely say it is tight. When you look at some of the other postural types, when you see that, those were supposed to, the muscle was either supposed to be long or short, this is how we know, is because we're looking at these length tests. So that's the next piece of this. The last piece of putting everything together for corrective exercise. And really what you're going to see is the tests, the length test and the strength test, turn into corrective exercises. But the third thing that we need to do after we've identified the postural types, we've identified all of those length tests, now we've got to come back and we've got to pick up the strength tests. And some of them we've already done with your manual muscle test for the upper and lower extremity, but we have not yet shown you what you can do for strength test of the trunk. So that's going to be the last thing in terms of the assessment part of this, and then we will get into the corrective exercise.